Okay, so the first thing I'd like to do is introduce myself. My name is Noelle Bassi, and I am the Internship and Study Abroad Coordinator here at the Harrington Center at Colby Sawyer. And Jen is also on here too. She's just popped up. There she is. She's the director of the Harrington Center as well. And we work to put together some resources for students. And like I said, this will be recorded. So this will be used as a resource for students going forward. I'd just like to introduce our panelists one by one, and then each of them are going to have an opportunity to talk and expand a little and kind of share all of their industry knowledge. The first is Jean Tenhaken. She is the Chief Operating Officer and Chief Nursing Officer at Alice Peck Day Memorial Hospital. Then we have Matt Petrin, who is the Director of Sports Medicine and Therapy Services at New London Hospital. We have Hope Damon, who's a registered dietitian at Nutrition Counseling Center here in New London. And then Evan Bick, who is a clinical psychologist at Dartmouth Hitchcock. And if, Jean, if you could take things away, I'm gonna share some information on each panelist, hopefully to give you a little more in-depth. You can read about it kind of while they're talking, and then also maybe have some questions based on that too. So Jean, if you would like to start.
Yeah, and if actually, thank you so much. I appreciate that, and I'm happy to be here. So my understanding is our audience are folks who are exploring possible careers in health-related fields. Is that correct?
That is
so
true.
everyone's path is still somewhat uncharted. So maybe a direction, but not quite sure. And that is not my bio. That's
mine.
Yeah.
Oh, sorry. There you go.
There, I am. Yeah, so I have never regretted choosing a path in healthcare. I have always wanted to be in a career where I was helping others, which is kind of the typical comment that you'll hear people who are either in nursing or medicine or some related field that, you know, we wanted to help people. I wouldn't say nursing was a calling from the time I can remember, but I certainly was always interested in science and math and well-being and staying fit and being healthy. And when I approached needing to make a decision after leaving high school, I decided to go to a university that could allow for me to have some different options. I knew that it had a great nursing program, but was also good for pre-med. So truth be told, my first year was actually a pre-med track. And as I got a little heavier into what my future was going to look like, I was really intrigued by nursing. So spent a little bit of time actually talking with the dean of the School of Nursing at University of Wisconsin-Eau Claire before I decided to officially change my track. And that was important, and I think it's a little more flexible now than it was back in the 80s, but you needed to be very timed in the program, otherwise you would need to wait a full year until you could get some of the experiences. So that decision was made, and the path for me was really set, and I've never looked back from there. And I think, as you can see, you know, why should you consider a career in healthcare? And I've got 6 or 7 bullets there. Is that I've always had a job. I've always had meaningful work wherever I've lived. I'm married to a retired naval officer pilot. So we've moved to several different places in the United States. I have not had any opportunity to live overseas. But I've always been able to get a job, and I was able to raise my children and balance that with working part-time. And I have always been able to look at opportunities for continuing education. So I did decide to go back to graduate school and kept along the tracks of clinical specialist in nursing, and have been able to build on those in the various positions that I've had. I consider myself what I would call an accidental administrator. It was never really a career goal of mine to be a chief nursing officer or a chief operating officer, and opportunities just have presented themselves, especially within the last 10 to 12 years, where it's felt like a little bit of a stretch for me, and some really good mentors of mine. One of them being Susan Reeves, who some of you might know since she was the dean at Colby Sawyer for many years. You know, just when you think that that you've hit the ceiling, take that leap and don't look back. And I've always been a little bit of a risk taker, calculated risk taker, and have found myself in progressive leadership positions. And I find myself today enjoying a dual role as a chief nursing officer and chief operating officer, which really allows me to keep my roots in nursing, which is all about taking great care of patients, and very proud of my background in nursing. But as a chief operating officer of a healthcare organization, really need to think a little more broadly about everything that goes into running an organization. I've spent a lot of time in the last few months learning a lot about asbestos abatement and permitting, because I'm in the midst of renovating our former birthing center into a surgical short stay unit. So I've never been without something to learn or know, and have relied on subject matter experts to help me be successful in a role that I feel like I'm continuing to grow in.
Thank you, Jean. I want to give students an opportunity to ask any questions that they may have. The two students that we have on here. And if not, I was actually struck by the fact that you describe yourself as an accidental admin. And I was wondering about that, because I feel like, you know, I feel like that kind of shows like you're just kind of open to new opportunities and new pathways. So I kind of like that in a way, where it's not like you just want to be focused on one thing and that's all you're going to do. No, there's more to it than that.
Yeah, and yeah, and it really is true. I never envisioned my nursing career taking me to the places that I've gone. You know, my biggest job was recently in Manchester, New Hampshire. I was at Elliott Health System, and I left Concord Hospital to be the chief nursing officer at Elliott, which is a fairly large health system in the southern part of the state, and had an opportunity to be their chief operating officer for 6 months. And it felt risky, but it was an opportunity that you don't say no to. It was short-lived in that I was feeling that I was getting further and further away from my nursing roots. And Manchester, New Hampshire is not my community. I've lived in Grantham, New Hampshire the entire time that I've been in the state of New Hampshire, which has been the last 24 years. And actually, Alice Peck Day is the organization that I had both of my children at when they were still birthing babies, and I've received all of my primary care here. So it was important to me at this point in my life, I'm 55 years old, to really want to spend time giving back to my community in a way that was feeling meaningful to me. So I always say, you know, look at an opportunity, and what do you have? You have nothing to lose by asking questions, pursuing it, and applying for a position for which you think maybe is a stretch job or something that feels a little bit foreign to you, but you have nothing to lose by being curious and seeing if this is something that might really be an opportunity that you've never considered before.
Yeah, I like that. And then also, did you miss the direct contact with patients? Because I'm assuming as a higher level admin, you're not as involved with the day-to-day patient interaction.
That is such a good point, and I feel like I've progressively made that leap away from the bedside when I stepped away from critical care nursing and got into case management, which was still very involved with patients and families, but in a different way, more about post-discharge plans, psychosocial support, as well as the clinical aspect. So I felt like I made a little bit of a leap away from direct care, and then really it took me about 6 years to step away from no longer feeling like I need my advanced cardiac life support, because you start really focusing on other things, which is why I got certified in executive nursing practice. So a different body of knowledge unto itself, but just sort of an evolution. I never have lost track, though, of my love for clinical nursing, and especially in the small organization that I'm in now, I get to round on patients and staff every day. My mom is 92 years old, and she still, I think, thinks of me as a nurse with my nursing cap on from 1986. And she said, so what do you actually do all day? And a way that I've described it is I actually take care of the people who take care of the patients, because that's really important. So I feel that I'm still indirectly taking care of patients because I'm making an environment that people want to come and work in and work for taking care of patients. So I take care of the people that take care of the patients.
I like that. That's a great way to put it. All right, Jane. Well, thank you very much. I'd like to ask Matt to talk a little bit, and we'll switch to his slide. There we go.
There we go. All right. Can everyone hear me fine?
Yes.
All right, good. So I was told by Noel that I have, 10 minutes to talk, and I can't even have a conversation with myself.
No, I'm not limiting you.
I can't even have a conversation with myself in 10 minutes, if you know me. So, I think a little bit about my background. I did graduate from the University of New England a while ago now with a BS in occupational therapy. I am in leadership position now as the Director of Sports Medicine and Therapy Services here at New London Hospital for the past 9-10 years almost now. So that's kind of enticed me to go back to school, and I attained my MBA in healthcare administration in 2019, spring of 2019. It was a very long 20 months of straight of education to go back and try to redo it again. And I found I did it much better the second time than I did the first time. I was much more organized. But again, kind of like what Jean was saying, it's when you're in healthcare, whether you're in administration or you're in clinical care, I think coming from a clinical background, that drive for continuing education is always there. And I think, kind of building off that, going back to school was really important for me. It didn't necessarily give me any more rights or a different position. It made me more confident in the job I'm doing, and actually is helping me understand my job a little bit better. As a therapist, as an occupational therapist by trade, we tend to have pretty big egos, and we think we know everything anyway. So going back to school, it was a good gut check as well to say, hey, wait a minute, you thought you were doing it right and you did it okay, but you can do it much better. So there's always that pursuit. So when I graduated from school in 1995, I started my first job at Brewer Rehab and Living Center that was up outside of Bangor, Maine. And I stayed there for about a year because I grew up in this region. I'm a graduate of Kearsarge High School. I grew up in Claremont, as many people can tell from my accent. It's just, I can't get away from the area. And I think that's what it comes down to. I came back from Bangor, the Bangor area, thinking I was going to take a job at New London for a year and see what it brought. And 23 years later, I am still at New London Hospital and in a leadership position here. So it's been really interesting, and it's been interesting to watch healthcare change over that time as well. And I think anybody who's been in healthcare for a long time has been able to see the changes and sort of the flexibility you have to really make it work in healthcare with all the changes that happen. It's an ever fluid sort of profession. So so I'm really here to talk about, the occupational therapy end of things. And the question I always get is, what's the difference between OT and PT? What's the difference between an occupational therapist and a physical therapist? And it can sometimes be really hard to discern what the difference is. And it depends on the setting and it depends on the situation. And a lot of this has to do with the roots of occupational therapy. And I'm not going to get you back, I'm not going to bore everyone with the history of occupational therapy in depth, but really, OT stems out of a mental health background, which I'm sure, Evan, you can probably appreciate. It stems out of a mental health background where when in the early 18th century, when people had mental health disorders, they were generally incarcerated at that time. And what was happening is as they moved more away from incarceration to asylums back in the mid 1800s, there were groups of people that started really using occupation as a way to engage people with mental health disorders. So, and occupation is really defined as everyday activities that people do as individuals, families, or within the community that brings meaning and purpose into their life. So these include things people need to do, want to do, and are expected to do. So that's a real broad definition of occupation. So when we talk about occupational therapy, we're not talking about, yeah, I have a job, I don't need occupational therapy. That's not the occupation we're talking about. We're talking about daily living and daily living skills when you talk about occupation. So, what they were finding is in the mid 1800s that occupational engagement with these patients in the asylums was really showing a benefit. And what happened over the years, OT really started to get its roots a little bit more and more from sort of borrowing from physical therapy and borrowing from nursing and borrowing from, to really define themselves around this occupation model. So it really started to flourish during World War I, World War II, where occupational therapists, and assistants at the time, as they were called, were using human occupation and those daily activities to help rehabilitate veterans, both physically and mentally. And it really started to go more from sort of handicrafts and, I've heard all the jokes as an OT, it's all, you take your underwater basket weaving class and that's, what OT does. Well, at first it was a lot of crafts and arts and crafts to engage people with their hands and limbs and help rehabilitate them. And then it really kind of switched over to the focus being that sort of occupation or activities of daily living, instrumental activities of daily living. And that's really where the profession is kind of taken off. So when we think about the difference between occupational therapy and physical therapy, it's really more the focus of the therapy being done. Physical therapy, you think you're going to strengthen, you're going to, improve range of motion, you're going to get these things back and better so you can walk and have the strength and do your daily activities. Occupational therapy is, yeah, we may work on the strength and conditioning, but we're doing it so you can participate in your daily life. So the focus is a little more holistic on the OT end, I think. Especially since it was really taken from bits and pieces of every other medical profession back in the day, helped make it a little more holistic. And looking at the whole person and sort of that functional use of self, and really kind of, it's a nice, when you do therapy with occupational therapy, there's always that purpose at the end. And I always feel like there's that purpose that you're really helping someone get back to their life again. And I think that's where the goals for occupational therapy stem from, is getting back to life and being able to participate in life again. And that could be, again, through increasing strength. So I've worked both as an inpatient occupational therapist and as an outpatient hand therapist. In the outpatient hand therapy, it is very blurred between what a physical therapist does and an occupational therapist does. It's just OT kind of inherited the hands in outpatient because you need your hands to do a lot of your daily activities. So it really lends itself to being more OT based and function based. Inpatient care, it's a little bit different than that. That's where you're really focusing on using those daily tasks to rehabilitate someone. It could be somebody who's had a stroke, and you need to teach them how to tie their shoes with one hand now for the first time, or help them with some adaptive equipment, or, you know, after a total hip replacement, really helping them be able to do those daily tasks. And it's fun to watch the profession spread out a little bit. Health systems are starting to use OT in the emergency rooms to do evaluations to help them there. And I was thinking, really, OT in the emergency room, how's that going to work? Well, you think about that new single mom who's fallen and has fractured her arm and is home with a baby. How is she going to change the diaper? Well, that's where they're calling in occupational therapy to say, hey, can you work through this with her? Can you work through this to get her so she can live her daily life and work around her disability right now, and rehabilitate her to get her back to being able to do it functionally again in the future. So that's a little bit about OT. I have to confess, I did not start school as an occupational therapy major. I started as a physical therapy major. I had no idea what occupational therapy was until I started school and started researching it more and went, you know, that's really kind of cool. You know, I started to look at it from the perspective of just the differences and sort of the approach differences between OT and PT. And I kind of said, you know, that's really cool. I think that suits me a little bit better. And that's when I made the switch in school to then end up going in for, you know, occupational therapy. And and just as Gene said, I've been able to be employed ever since I came out of college. I haven't had to worry about that. You know, I think certainly with the pandemic that's going on, you know, we're essential workers still. And I do feel a little bit of, again, what Gene was saying, I've been a little bit more removed from patient care, but I still definitely keep my hands in it and cover whenever I can, just because it makes me smile every time I get to do it, because I'm working with patients again, and I get you get that, there's a therapist rush that happens. And I'm sure nursing gets that rush too, when everything just seems to go well and you really feel like you're making a difference in someone's life. It's a great feeling to come away with as a therapist. And those feelings, they don't come with every patient either, but they do come with a lot of them. So it's an exciting profession to get into. I think it's a growing profession. It's definitely needed. And, you know, that's where I stand. I'm going to stop talking before you tell me to stop more.
No, you're great. Thank you. I want to, of course, allow students to jump in at any point. Matt, I was actually struck by the longevity of your career. Like, you know, you like this area, you know you do, and you've stayed here in this, and you've grown with your career. So what was your inspiration, or how did you know, like occupational therapy and physical therapy are not the same, but they are somewhat related. So you started as a rehab therapy major, right? And then
I
moved on
started
to
as a physical therapy major,
physical.
actually.
Okay, sorry.
Yep.
So I
So,
don't know, how at 20 or 18 did you know that that was the direction? I find that amazing.
actually, one of the dean of students, it, it was very interesting. So we had a dean of students who was he was very involved. He was involved with the athletes at the university, and he talked to some of us. He was a professor, he's an occupational therapy professor, and he started talking to us. He was also the liaison outside of athletics to the NCAA, and so he would talk to the athletes, and he got talking to me at one point about what occupational therapy really was, and it clicked, and it went, this sounds really, it sounds, I hate to say it because it sounds terrible when you talk about physical therapists, it sounded more, less sterile, I think. I don't know, it sounded a little more organic, like, hey, this is really a little bit of everything together. And not to downplay physical therapy, because certainly they are terrific as well. I have a lot of therapists who work for me, but it just felt right. And I think that was it. But I didn't know anything about it until I got there and was able to talk to other students and talk to, the dean. And then it just kind of clicked, and I went, okay.
Right.
So.
And then I also noticed you really have incorporated, like you like to do a lot of outdoor things. So, this enables you to do that, which I think students do want, that work-life balance for sure now. But it looks to me like you even went a step further, and let's see, you were at Full Circle Farm as a therapeutic, or doing therapeutic horsemanship.
So I'm actually on the board of directors for the farm there for the therapeutic riding program in Newport, New Hampshire. So as soon as I got my MBA, they made me treasurer, so I don't understand. So I get a little extra title in front of my board of director name now. But that actually stemmed from there was another person involved with the program, and I actually worked with their mother when I was a inpatient therapist here at New London Hospital. And they knew that I was still here. So they reached out to me and said, hey, how'd you like to be on our board of directors? And we're starting up this program. So I can't say no. So I went for it. It's been a hugely rewarding experience. It's such a great program. If anybody here in the area gets a chance to check it out, they're in Newport, New Hampshire. I got to throw a pitch for them. Got my New London stuff on, but I've got to throw a pitch for the Full Circle Farm. They do a terrific program working with veterans as well as youth with varying disabilities and different abilities, I think, as their background. So it's a very rewarding program.
We've actually had a few interns go there over the past couple of years too. I had the opportunity to tour, and it's lovely.
Yes, we've enjoyed your interns there. They've done a great job for us.
Oh, good. Yay. A good plug. Thanks for mentioning that, Jen. Okay. So, great. So students can jump in anytime, of course. But Hope, if you would like to start.
Sure. So hello, everybody, and thank you, Noelle, for the opportunity. I have been a dietitian for 41 years. I think I'm the oldest panelist doing the math here. And I have to say, I have really loved my experience in healthcare. There are commonalities with what Jean and Matt have said, the sense of purpose and of helping people. When I'm asked to describe what I do, my tagline is I say I help people take better care of themselves in a way that is sustainable and a good fit for them. So I'm an RD, meaning registered dietitian. I'm also a CDE, which is certified diabetes educator. And I do work with people on how they eat and how that treats disease or prevents disease or promotes general wellness. A lot of my work is in weight management and in helping people with eating disorders, obviously the diabetes. Those are kind of my three things I hang my hat on. They're more similar than one might think because it's really all about helping people decide what their values are and what's worth it in terms of how we manage food. I really, really love food. I think it is something that is supposed to be one of life's great pleasures. I think initially a lot of my patients are surprised that I am not the rule-driven, do this, don't do that. After this long, frankly, nothing surprises me about what people want to eat or what works for them or doesn't work. My office is non-clinical, spacious. Sorry, I didn't put the visuals together because of time crunch, but plants and cookbooks and teddy bears. And this is a sign that a patient made for me because apparently in our eating disorders work, she would ask if she could sort of get away with something. And I'd say, well, if you do this and this, then you can do that. And I said if enough times that when she graduated from care, AKA really got pretty recovered from her eating disorder, she gave me the if sign, which leads to a lot of interesting conversations here. I like to teach with art and visuals, and I have a lot of things around the office that are props for doing that. So background, I have a bachelor's degree in nutrition, which to become a dietitian, you either get a BS in nutrition or some health medical related field, and then do an internship. Internships are extremely competitive to get. There are less than half as many as are needed in any given year. So there are some other routes to internship, and our national certifying body is vigorously working on ways to have more opportunities, but I would be misleading if I said it was an easy option or a guaranteed option to get into being an RD. Most people do eventually get an internship, but they don't necessarily get them the year they graduate from college, which in most cases would have been what people would have preferred to do. I started my work career as a dietitian at New London Hospital, and one of the prompts Noelle gave us in inviting us to speak was to talk about how you get a job or an internship and, you know, what experiences did you have in that way. When I was finishing my internship overlapped with my undergrad, and it was extremely intense. I basically did 4 years in 5. So I couldn't figure out how to look for a job while I was doing that. I was just like, I can't do that. So when I completed that, I worked for a summer in Spofford, New Hampshire, which is west of Keene. It's almost in Vermont, at a beach club. Easiest job I ever had. And it gave me opportunity to look for the proverbial real first job. I was reading the Boston Globe looking for job ads down there because I went to school in Framingham near Boston, and I thought I'd relocate back down there. And a little, literally 1-inch square job listing for food service director / clinical dietitian at New London Hospital changed the rest of my life is from there. I came up here for an interview, and I literally came because I was delighted I got an interview, and I just wanted practice with interviewing. I didn't even want the job. I wasn't even qualified. However, they hadn't had a dietitian for long enough that it was going to become an issue in accreditation. And they were thrilled to have somebody who would take this job. So there I was. I did food service management and clinical nutrition, mostly working with inpatients. There wasn't a lot of outpatient work at that point, for 7 years. And I learned so much about people and life and, you know, what kind of work I liked in nutrition, and decided that I didn't want to be a manager of people anymore. I had about 25 employees that reported to me, or 25 full-time equivalents, and that I wanted to get back to my training and roots in nutrition. I was married at that point, had gotten married about a year before that, to a guy who was building a construction business here, and we didn't want to relocate, much like Matt. We love this area. Neither one of us is from here, but it's in my soul. I'm a country kid and I love change of seasons and outdoor activity. So long story short, in getting back into fully being nutrition, not food service management, there simply weren't a whole lot of nutrition jobs in what I considered a reasonable commuting distance. I had spent a lot of time commuting as an intern and had established I didn't want to spend 2 hours a day sitting in a car or public transit, that I had other things I wanted to do at that time. So I went to a 3-day training on private practice, essentially starting your own business as a private practice dietitian. And about a year later, I resigned from New London Hospital and opened my practice. And I think being an entrepreneur is for some people and not for everyone. I don't come from an entrepreneurial family. When I said I was leaving my good, secure job, my mom said, "What will you do about health insurance?" She did not congratulate me. Scared everything out of her. I think I was probably pretty snarky, and I said, "I will buy it. I'm going to earn a living doing this, and I will have health insurance." Fortunately, my husband's family is very entrepreneurial, so he was confident, and I decide how I do things. I decide what my space looks like. I decide when I work. When I don't, I work a lot. I've always worked a lot. I like my work. Self-employment doesn't come with an income guarantee. You have to have some degree of business sense or learn it. I think people in healthcare generally, we did not used to be trained to think about the cost of our services. You know, what we're worth, what health insurers or people will pay, what the value is. That's a whole world different from being a foodie dietitian. But if you're self-employed, you had better learn how to have a business sense, or you probably won't last for long. That was really hard for me in the beginning. The best business decision I ever made, other than going into private practice, was deciding that I was not the right person to file insurance claims and send invoices to patients and keep track of that. I'm terrible at it. I hate doing it. When I hired somebody to manage my practice, I literally doubled my revenue in a year. I don't do this for the revenue. I do this to help people. There is nothing more satisfying than when somebody succeeds at meeting their health goals in a way that they can sustain. But I couldn't do this if I wasn't also earning a living. I can't do it as a volunteer. So it's that balance of business sense and making it work. Let's see, what else? Humor. I don't think there's enough humor in the world or in healthcare. There is a lot of laughter in my office because I find the funny in things kind of easily. And I have feedback from many patients that they love that they know even when we're doing really hard stuff, whether around blood sugar management, medication adjustment, challenge foods for somebody with an eating disorder, coming to terms for somebody who's very large that maybe they're not going to be the lean person they would love to be. They could lose, but they may still be a very large person, and that may be the best they can do. People love it when you can find ways to make it a little bit lighter and a little more humorous. So I kind of cultivate that in my approach and work. The other thing that I don't actually think I cultivate, but it is valuable, I like to say I don't have a judgmental bone in my body. I don't find it acceptable that in our culture we judge people based on their size and their appearance. Bigotry against people who are large is still extremely entrenched in our culture, and it's wrong. I never miss an opportunity to say that. And I hope I create a place that my patients can be whatever size they are and work on how they take care of themselves without feeling like they're treated differently than someone who's smaller. It's an intense passion of mine. There are some similarities in what the two previous speakers have said. Ongoing learning, never bored, challenged throughout every day, diverse employment settings. Other dietitians work in all kinds of different settings, from hospitals, long-term care, sports clinics, business, communications. It's a diverse profession. There are lots of different kinds of opportunities. What else? I'm just glancing over notes here. I think, in my rambling way, I do ramble. Oh, one more thing. This is not per se about being a dietitian, but it is also something that I don't miss an opportunity to share. I had breast cancer last year. It is very interesting to be the patient when you have been the healthcare provider for all of your life. And I have been a very, very healthy person. I couldn't say enough good about the wonderful crew at Norris Cotton. Just respectful, kind, informed care. Very, very well delivered, and my bar is high. And I like to say to people, cancer is not anything anybody wants, but honestly, it wasn't nearly as bad as what I often have heard. And I think it's good for people to know that, sometimes chemo's not horrendous, treatment is manageable, and then you just keep going on. So I throw that in.
Well, wow, thank you for sharing that. That was really personal and really it's good to get that perspective from, the patient end versus the caregiver. And so you answered all of my questions, but I think what I'm going to do is just underscore sort of some of the things that struck me from, your path and all of that. So, and I guess a little clarification on when you decided to start your own business. That was in 2003, is that right?
Oh no.
Sorry.
It is so long, I don't even remember. 87.
1987 is when you started the Nutrition Counseling Center. Okay. So can you sort of because you were doing a lot of obviously other things during that time, I can see from your bio here. So what made you what made you just decide that you were going to fully focus on this and all this other stuff,
So it really evolved when I wanted not to be in food service management anymore, and I wanted to do nutrition and patient coaching and educating. And I also needed to earn a living. Mm-hmm. There were actually not a lot of dietitians in private practice nationally. I was the third dietitian in private practice in New Hampshire.
Wow.
So it was not abundantly clear that that model of practice would work, especially in a community this size. Mm-hmm. But I think I had some advantages in that, having worked at the hospital, I knew all the docs who might refer to me. The little old shopper, all advertising news thing is a very unusual medium, but in New London, people read it. New London, Sunapee, and parts around, this is pre-social media. There was no social media connections. So I could advertise in there and become visible in a different way. But I had, and they're on my resume, a number of consulting positions that were both to expand my expertise and, predictable income. I worked at 2 different facilities, residential facilities for alcohol and drug rehab, that really informed my practice in behavior change and in, I think, just a greater sensitivity to that population that is, you know, so present and much more so now, but it was not an area of expertise that I had. One of the psychologists at Spofford Hall where I consulted, he and I, at some point a few months into my employment, were collaborating with some patients who were both there for their dependency work, but also had eating disorders. And he said, do you think there are more people with eating disorders in the substance abusing population? And I was like, I have no idea. Well, there wasn't any data. And we did this very private study. It was never published. We just kept track of stuff there and looked at it compared to the data on eating disorders in general. And basically our answer was yes, they're very co-occurring or sequential. And so we need to treat, obviously, co-occurring diagnoses need treatment at the same time. And that has certainly influenced what I have seen in my practice and helped me a lot in my developing my eating disorder skills and continuing training for that. I think the point at which I said, I'm not going to do the consulting jobs anymore, and they were one by one. It was just each one for different reasons. One of the alcohol and drug rehab places closed, so that was the end of that. Various different things, and then I had kids, and I have two wonderful grown daughters. You know, I didn't want to work full time at that point, and I wanted all my energy to be to my practice. And then, you know, as they got a little bit older, I was back full time in practice.
Yeah.
You know.
Very good.
So.
Excellent. Thank you, Hope. If we can move on to Evan, and I will get your screen up, please. Thanks, Evan.
All right. So I'm.
Oh, oops. Sorry. Keep messing with things here. There we go.
All right. So I'll sort of try to briefly go through what my experience has been, you know, leading up to my role now at DH as a psychologist in the sort of outpatient psychiatry department. You know, I realized as some of the other folks were talking that that, you know, my title is psychologist. I have a license to practice psychology, but I am a therapist, and there's lots of different professions that are therapists, that are sort of psychotherapists, I should say. And so I won't and really can't talk with any knowledge about sort of different ways into similar roles, but I'll at least sort of name them. You know, so there's sort of several groups of people with different qualifications who are all doing broadly similar things in terms of providing psychotherapy. And so one group is psychologists who generally have a sort of a doctoral degree in some sort of psychology. There's social workers at sort of master's and independent licensure level, LMHCs, which I believe is a master's degree. It has its own sort of licensure process within New Hampshire. Those are sort of the big ones. There's some smaller groups. There's pastoral counselors, which are sort of are priests or pastors who are additionally sort of trained in providing counseling. So I just wanted to sort of at least name that before I go on and ignore it all and just talk about what my experience has been. So I sort of took a different path into the mental health field. So I was a poli-sci major in college. It seemed fun. I joined the Army after I left college and was in the Army full-time for about 4 years, and then in the Massachusetts National Guard for another 2 years after that, totally unrelated to the mental health field. And then as I sort of was transitioning out of the Army, I was trying to sort of think of things to do that might sort of be interesting and give me an opportunity to sort of continue, not obviously directly using some of the same skills, but using some interpersonal skills that I kind of thought I was pretty good at and enjoyed a little bit. And so I found myself connected with it's going to be confusing because it changed its name, but when I was there, it was called Massachusetts School of Professional Psychology. It changed its name to William James College a couple of years ago, which is a sort of standalone graduate program in Newton, right outside of Boston. And they had a lot of different programs, but some that sort of appealed to me in particular. They had a sort of growing program in the program was literally called Train Vets to Treat Vets. It was not creatively named. It was literally designed to reach out and find sort of military veterans who are interested in entering kind of mental health roles. So I was involved in that in a couple of different ways as I went through graduate school. Going through school, I had a lot of different sort of clinical experiences, from doing in-home psychotherapy. I think literally in my second week of graduate school, which was mildly terrifying. So literally my supervisor kind of drove me to somebody's house and said, "Hey, this is Bob," or whatever. And then she drove away, and I was just doing therapy and not really knowing what I was doing, which was a good, I don't know if that's actually how I learned to swim, but it was a good way to learn sort of therapy. And so I came up here. So the way the process works in the sort of training process works in psychology is as Hope mentioned, in diet. I'm trying to turn dietitian into a noun, and I'm failing. In the field of dietary studies.
Dietetics.
I was going to say dietetics, but
Yeah, you were there. It's all good.
I thought I surely must have been making it up. So the path that most people take, which makes sort of licensure easier, is a sort of centralized full-time internship after graduate school, which lasts about a year. As in dietetics, which is a word I now know, there are kind of often more applicants than slots, and similar to the way medical residency works, you sort of send in your applications and sort of rank where you want to go, and all the programs send in their preferences of the applicants, and they stick it in a computer and shake it, and then they tell you where you are going. And it is not discretionary. You once they tell you where you're going, you have pre-committed to going there. I really wanted to. I knew sort of on paper that wanted to sort of come up to this area, and was fortunate that I matched at White River VA for their internship, which lasted about a year, and then got a fellowship or a postdoc at Dartmouth Hitchcock, treating sort of mood disorders and anxiety disorders. So different states are a little bit different in terms of licensure, but essentially all of them require a full-time year of supervised practice before you're eligible for licensure. So that can be part of a sort of formal program, as I did at DH, or sort of there's some opportunity to kind of build your own program if you can find people who are able to supervise you. So I did that. I sort of took the opposite route from Hope. I finished my fellowship and joined a small group practice in Lebanon, and decided that was not for me. That I really enjoyed being part of a sort of bigger organization, of a bigger department. And so after about a year or so, I decided to come back to Dartmouth Hitchcock. And I've been in my current role for about 2 years or so. So I'm still a pretty early career psychologist. So I work, I'd have to look at a calendar to be sure, but generally I spend about 30 hours a week doing direct individual therapy, and then another 4 or 5 hours a week doing groups, and then some sort of administrative work to catch up. And then I also have some involvement in different teaching and training and supervising roles throughout DH, which has med students and residents and psychology trainees and all sorts of levels of training. So I'll say sort of briefly some of the things that I think have sort of, that brought me into the field of being a therapist in general, and that I like about it. You know, I'd sort of describe my role as generally kind of helping people understand the connection between their thoughts and their feelings. So generally people sort of come into treatment because of a feeling, because they're sad or they're anxious or they're scared. And they've tried all sorts of things to sort of directly change that feeling, and found that it hasn't worked very well. And so I would say I probably spend most of my time helping figure out, you know, what the sorts of thoughts are that are contributing to those problems, and what might be a different way of changing them. You know, I think the things that really appeal to me about this are the opportunity to work with people. Certainly, I feel like there's probably a certain amount of extroversion that helps sort of, you know, enjoy talking to people that you've never met before for 30 or 40 hours a week. And also just sort of I think if you zoom out far enough, it seems sort of, oh, you're always talking to people with depression, or always talking to people with anxiety. But I think at the sort of individual level, that everyone is different, and it's interesting and challenging, and occasionally it sort of works and feels satisfying and helpful to come up with different ways of sort of, again, sort of working with people to solve some of those problems. I'll briefly say, I was going to say this before, but hope mentioning Norris, the CCC, brought it up again. I think, so I work in the sort of probably the most traditional psychologist role. I sit in an office and I see people, you know, for basically 45 minutes at a time all day long. And that's a model that I like. I guess right now I sit in my bedroom in my house and do it by telephone for 40 hours a week, because I have been nearly entirely tele since March. I go into the hospital every once in a while, but not very often. But we have sort of psychologists and social workers and you know, mental health, behavioral health counselors and LMHCs sort of really spread throughout the entire Dartmouth system. So we have psychologists, obviously within psychiatry, but also within gastroenterology, couple primary care in a couple of different ways, the cancer center, pediatrics in a couple of different ways, the emergency department, obviously, and then also have, you know, embedded within primary care and internal medicine, have a lot of different health counselors who are sort of able to work with patients at, you know, a somewhat less structured way than the kind of classic, you're going to come into my office for an hour a week and we're going to talk about feelings. I'm just going to glance briefly at the notes I had left to myself to see if there's anything I wanted to mention. Yeah, I think I'm probably repeating what other people have said, but I think as a career, I think one thing that is particularly true of therapy, of psychology, is the ability to sort of work in all kinds of different systems, you know, from you know, totally independent private practice, you know, hanging the shingle on one extreme, to sort of, you know, embedded within, you know, something like the cancer center, which is obviously a sort of a huge organization that has a lot of moving parts. One major sort of part of psychology that I haven't really talked about is sort of the role of research within psychology. There are, I'd be making up a number, but there are at least as many sort of psychologists who are more or less primarily engaged in research as there are in therapy. It happens that my focus has been nearly entirely on clinical work throughout my career up to this point. But that probably is certainly not the overwhelming majority. If it's even the bare majority of psychologists in the country, I'm not quite sure. But I'll just sort of add in terms of talking to people who are sort of considering about what routes to go down. I think, my example is sort of interesting in that I very much was not the sort of day one of college psych major committed, definitely going to be a psychologist. I'm pretty sure I took Psych 101. I don't really remember. And for a long time kind of thought that ship had sailed, so to speak, and found that, there's a little bit of sort of work that has to happen to make that work, but it is certainly something that is a field that you can get into, even if you haven't taken the most traditional path. We had, in my sort of cohort, we had, I think they said that I was about the median age. I think I was like 27 when I started, but I was like the only person at that median age. We had a lot of people who had just graduated undergrad, and a lot of sort of second career people or people who had been doing other things, either other things entirely or sort of other things within the kind of broader healthcare umbrella, and decided that they wanted to transition into psychology. So, I think that's pretty much all I have. I'm happy to answer.
All right, thank you, Evan. Something I found interesting about your path was that it kind of just melded into each other. It was started out as something very different, and then, but each step sort of slowly took you to this. So you started out as a political science major, and then that led to joining the military, which are somewhat related. And then I'm wondering if something in the military, did you see something that like piqued, like you thought there's a need for?
I think it was, there's this sort of a broader and narrower answer to that question. I think, in the role that I was in, I think there was a lot more sort of counseling adjacent stuff happening in my job than I probably would have guessed. A lot of sort of direct leadership and working with, I almost said patients, which is terrible, working with soldiers to help manage and cope with a lot of different kinds of stress, family stress and obviously job stress and sort of history of trauma exposure sorts of stress. And I think that's something that if you had asked me, before I was involved in the military at all, I wouldn't have guessed that was sort of a thing at all. Certainly not outside of sort of explicit, like I am a military psychologist or something like that. But it really takes up a pretty significant amount of sort of, a military leader's daily life. And I started to find that I sort of enjoyed that part of it and was at least reasonably good at it, and was looking for sort of ways to sort of transition into civilian life while kind of holding on to the things from that experience that it felt helpful, I guess. Yeah, I was sort of struck listening, to everybody else's sort of story, how many, the details are different, obviously, but a lot of sort of, I don't think anybody said, I woke up on my graduation day in high school and decided what I was going to do, and then I've been on a clear path, up to that point. That's just not a thing.
No, right. And I think that's important for students to know, like, even starting out in college, your paths can take many different turns and twists, and that's why I think hearing about career tracks is so important. It's like, if you miss an opportunity, there could be another one, or if you take this opportunity instead of that one, something can grow from that. And I think it's all just a learning experience. So I think that's important to communicate that to students so they know that, you don't have to be on the straight and narrow the whole time. You can divert. So could I ask if each of you wouldn't mind sharing your contact information in the chat?
Sorry.
Oh, King, sorry.
Yeah, I just had a couple questions. If you did, sorry. For Evan. So like I want to go into psychology in some aspect. But like you're talking a little bit about like flexibility in research or clinical settings. How accessible is that kind of down the road more? If you kind of get into a like if you got into a clinical practice and you found you didn't really enjoy it, or you'd rather do research.
I think it's probably easier to go from research to clinical than the other way around.
Okay.
You know, I think once you're sort of off the research path, I can imagine it being harder to get back onto it, but I don't really know. I'm sorry.
Okay. No, that's fine.
I do know that I think, you know, as we're talking about all these different kind of ways of being a therapist, I think research takes a much bigger role in psychology than it does in most of the other sort of mental health fields, I think.
Okay. And then you also talked a little bit about, you know, how it kind of stays interesting, but do you feel like that there's kind of enough variety and individuality in the patients that you see that it just doesn't become kind of repetitive? Or do you feel like you kind of see enough different sides of life that it stays interesting day to day?
Yeah, I think the sort of the short answer is that people that kind of sound similar on paper turn out not to be very similar in practice. But I need to step out for just 1 second. I'll be right back. I'm sorry, and then I'll put my contact information back up.
Thank you.
Okay. Great. Okay, well, yeah, as what Jennifer said. Yeah. Thank you very much for your time today. I really appreciate it. I think the students gain a lot of value from hearing like just the career tracks, the industry knowledge, and just sort of how people got to their path. And I do appreciate you sharing your information, I believe. Yep, okay. And yeah, I just really appreciate the time, and I know it's later in the evening on a Monday. So yeah, just thank you so much. And you know, hopefully the students will be in touch to maybe put together an informational meeting or a contact for, you know, whatever they need, internships, jobs, whatever. So, but I think informational meetings can be really beneficial as well. So I do appreciate your time, and I'm going to actually stop recording right now.